Am I audible? So hi everyone, if you are joining the session for the first time, this is Dr. Shanmugapriya. I am Professor and Head of the Department of Biochemistry at Government Thuthukudi Medical College, and I am your Unacademy educator for Biochemistry. And this is part 2 of FMGE MCQ marathon session. So in this session I will be discussing, good afternoon Alia. So in this session I've again chosen few previous year questions asked in FMGE papers, and we'll be discussing few high yield topics. Okay, and before we start the session, let me tell you few facts about Unacademy's plans. On Unacademy Android app, now we have something called as Compete, wherein aspirants, NEET PG aspirants can compete with a NEET PG aspirant, FMG aspirant can compete with, so depending upon your choice, you can choose whom you would want to compete with, and you can try. It will be a gamified way of learning, so do try this provision. When will you take rapid revision? This is a rapid revision, Kyati. This is a rapid revision session. Yeah, good afternoon, Mohammed. Good afternoon, Vairam. All of you, good afternoon. And this is a rapid revision for FMG, Kyati. And for you to boost your rank in NEET PG 2023, there are multiple batches which are happening on the Unacademy platform. So do register yourself for all these batches and get maximally benefited out of these batches. Because we have PYQ sessions, we have test and discussion sessions, image-based question sessions, and for all these batches, there is only one subscription. Okay, so try to get an access to all these exclusive batches, and the cost for 4 months would be 13,770. Good afternoon, Tarun. And this is the current NEET PG subscription plan. So as I told you just now, if you want 4-month subscription plan, the cost would be, give me a minute. So now it's working. I'm sorry for the delay in beginning of the session. There was some technical error with my pen, and now it works. So, so this is the current NEET PG subscription plan. So as I told you, for 4-month subscription plan, the cost would be 13,770, and this is inclusive of 10% discount. And to avail this 10% discount, you can use any educator's code. If you want, you can use my code, which is Shanmugapriya. Okay, so that's all about Unacademy's plans. Let's start discussing few previous year questions of FMG, and using those questions, let's try to learn about few facts and concepts. So this is the first question for you all. Drug of choice in mountain sickness is. This is an FMG December 2021 question. What do you think is the right answer, all of you? Drug of choice in mountain sickness is thiazides, furosemide, acetazolamide and spironolactone. All of you, please keep the chat box active. Very good. Very good, Mohammed. Yes, Tarun. Alia, Prithvi, all of you are right. It is acetazolamide. So quickly, let me tell you why acetazolamide is a drug of choice for mountain sickness. So what is mountain sickness? It includes all adaptive changes that happen when you suddenly climb uphill. So why are you worried about suddenly climbing uphill? Very good. It's a carbonic anhydrase inhibitor. Excellent, Vairam. Yes. So why are you worried about climbing uphill quickly? As the altitude increases, the partial pressure of oxygen in the atmosphere decreases. So there is hypoxia, and so the person hyperventilates. What will happen when the person hyperventilates? The person washes away carbon dioxide, and that causes respiratory alkalosis, because carbon dioxide is a source of an acid. Now, why are you worried about this respiratory alkalosis? Because your central chemoreceptors, which are present in medulla, respond only to increases in hydrogen ion concentration in the CSF. I hope you all remember that we have two chemoreceptors. One is peripheral chemoreceptor, the other one is central chemoreceptor. Your peripheral chemoreceptors, where are they present? They are present in aortic and carotid bodies. So please remember, don't get confused here. Baroreceptors are aortic and carotid sinuses. Chemoreceptors, your peripheral chemoreceptors, are aortic and carotid bodies. These aortic and carotid bodies can respond to all three stimuli. They respond to hypoxia, they respond to hypercarbia, they also respond to an increase in hydrogen ion concentration. This is about peripheral chemoreceptors. But what about central chemoreceptors? They are present in medulla, and they do not respond to hypoxia, they respond only to hypercarbia. Even that, they identify that there is hypercarbia only by checking the increase in hydrogen ion concentration in the CSF. Now, if a person hyperventilates and if there is respiratory alkalosis, CSF hydrogen ion concentration does not increase. So, central chemoreceptors do not get stimulated and the respiratory center is depressed. This is why you are worried about climbing uphill quickly. So, if one of the effects of climbing uphill quickly is respiratory alkalosis, you would try to combat this respiratory alkalosis by giving acetazolamide. So, what does acetazolamide do? Acetazolamide is a carbonic anhydrase inhibitor in the PCT. So I hope you all know that in the glomeruli, whenever you filter, you filter every bicarbonate into the filtrate. But can you excrete all the bicarbonate in urine? If you excrete all the bicarbonate in urine, bicarbonate is a major plasma buffer. So plasma lacks bicarbonate, that will cause acidosis. And that is why what we do in the PCT, you reclaim all the bicarbonate. Can you see that here? In the proximal convoluted tubule, you reclaim all bicarbonate back into circulation. For this, you need carbonic anhydrase, and that is inhibited by acetazolamide. So there is no bicarbonate reclamation. Without bicarbonate, your blood will show acidotic pH. And don't we want this? What is hypercarbia? Tarun has got a doubt. What is hypercarbia? It is nothing but increase in carbon dioxide concentration. Hypercarbia is increase in PCO2 more than 40, actually it is more than 44 millimeters of mercury. That is called as hypercarbia. In this case, the person hyperventilates, washes away carbon dioxide, so it is going to cause hypocarbia, that causes alkalosis. We want to counteract this alkalosis, that is why we give acetazolamide, because acetazolamide does not allow bicarbonate to get into circulation. Without bicarbonate, there will be acidosis, and that increases hydrogen ion concentration in the CSF, and the respiratory center is stimulated. Do you all understand this? So what is the drug of choice for mountain sickness? It is acetazolamide. To make it more complex, if they ask you why do you give acetazolamide in mountain sickness, your answer should be because acetazolamide inhibits carbonic anhydrase, thereby it causes normal anion gap metabolic acidosis. All of you please remember this. Acetazolamide inhibits carbonic anhydrase, thereby it causes normal anion gap metabolic acidosis, thereby respiratory center is kept stimulated. Is that clear? Now this is the next question. So how many of you have seen questions on oxyhemoglobin dissociation curve in FMGE? You all must have seen, right? This is being repeatedly asked. So what is the graph that is shown to you? The graph that is shown to you is oxyhemoglobin dissociation curve. What is the right answer? Which of the following shifts the given curve to the left? Try answering. Hypoxia, acidosis, anemia, decrease in body temperature. Mohammed says it is anemia. Do you all agree with Mohammed? Is it anemia which shifts the curve to the left? Ghost Rider says it is hypoxia. Is that true? Byram also says it's hypoxia. Tarun says, very good Tarun. What is the right answer? The right answer is decrease in body temperature which shifts the curve to the left. So let's learn all about oxyhemoglobin dissociation curve. All of you watch this carefully. How is this graph drawn? Whenever you're shown a graph, you should try to understand what is along y-axis and what is along x-axis. So how is oxyhemoglobin dissociation curve drawn? It is drawn with percentage saturation along y-axis. If you're asking me how do we remember this? Y and percentage look similar, right? Y and percentage look similar. So what is along y-axis? Along y-axis it is percentage saturation. Along x-axis it is partial pressure of oxygen. And in such a graph you're always worried about the position of the curve. You always want to know whether the curve gets shifted to the right or the curve gets shifted to the left. So what is this? This is shifting of the curve to the right. This is shifting of the curve to the left. Why do you want to know about shifting of the curve to the right and to the left? Because that tells you about P50. What is P50? Please start thinking and try answering to yourself and keep the chat box active. What do you think is P50? P50 is the partial pressure of oxygen at which it is 50% saturated. Do you all understand this? It's the partial pressure of oxygen at which it is 50% saturated. So what does shift of the curve to the right mean? Whenever I say the curve gets shifted to the right, then partial pressure of oxygen at which it is 50% saturated is increased. Do you all understand this? Shift to the right means P50 is increased. So what does shift to the left mean? If the curve gets shifted to the left, it means P50 is low. Are you clear so far? Shift of the curve to the right means P50 is increased. Shift of the curve to the left means P50 is decreased. Now what does low P50 mean? You should try to decipher every number that is provided to you. So what do you mean by low P50? Low P50 means even at such a low partial pressure of oxygen, even at such a low partial pressure of oxygen, it is 50% saturated, which means its affinity is high. So how are P50 and affinity related? P50 and affinity are inversely related. Are you clear about this? So shift of the curve to the right. Shift of the curve to the right means P50 is high and affinity is low. Shift of the curve to the left means P50 is low and affinity is high. Now my question to you is, when will you want the curve to get shifted to the right? When will you want the P50 to be high? When will you want the affinity to be low? The affinity of hemoglobin for oxygen, affinity of hemoglobin for oxygen should be reduced whenever you want effective deoxygenation to happen to the tissues. And when do you want effective deoxygenation to happen to the tissues? Number 1 is hypoxia. Number 2 is anemia. Number 3 is increase in body temperature. Number 4 is acidosis. So what are the conditions when you want effective deoxygenation to happen to the tissues? You want it to happen in hypoxia. Shift of the curve to the right should happen in hypoxia, number 1. Number 2, it should happen in anemia. Number 3, it should happen in increase in body temperature. Number 4, it should happen in acidosis. So why will you want to happen? No, Mohammed Rafiq, not in cyanide poisoning, it is carbon monoxide poisoning. I will tell you about it in a bit. For now, please memorize all the facts that I am trying to tell you. So, hypoxia, why will you want the curve to get shifted to the right? Why will you want the affinity to be low? Because hypoxia means there is low oxygen. If there is low oxygen, somehow you should give oxygen to tissues. How will you give more oxygen to tissues? By reducing the affinity of hemoglobin for oxygen. So, the curve gets shifted to the right. Anemia. What is anemia? Oxygen carrying capacity of the hemoglobin being low is called as anemia. Whatever is being carried, even if the oxygen carrying capacity is low, whatever is being carried should be given off to the tissues. So, affinity of hemoglobin for oxygen should be reduced and the curve gets shifted to the right. Increase in body temperature means there is increase in the rate of metabolism. Whenever there is an increase in the rate of metabolism, you should support that increase in the rate of the metabolism by giving more oxygen to tissues. So, affinity is reduced and the curve gets shifted to the right. Acidosis. Whenever a person is acidotic, your aim is to avoid further acid production. How will you avoid further acid production? You know, anaerobic metabolism always generates an acid. So, in acidosis, your aim is to avoid anaerobic metabolism and to support aerobic metabolism. How can you support aerobic metabolism? By giving more oxygen, by reducing the affinity. Is that clear? So, tell me what are the conditions wherein the curve gets shifted to the right? All of you try to answer this. The curve gets shifted to the right whenever you want P50 to be high or whenever you want affinity to be low. When will you want affinity to be low? Whenever effective deoxygenation should happen to the tissues. When do you want that to happen? Hypoxia, anemia, increase in body temperature and acidosis. Okay, so what did I tell you is the effect of anemia on the curve? I said anemia shifts the curve to the right. There is one exception to this rule, and who said it? Rafiq. Mohammed Rafiq was mentioning, you don't have to be sorry, Rafiq. I'm very happy that you're interacting in the live chat. All of you, please interact in the live chat. You can always say your answers. It need not be right always. Okay. So, in carbon monoxide poisoning, the curve gets shifted to the left. Why will there be a shift of the curve to the left in carbon monoxide poisoning? It is because carbon monoxide exhibits very high affinity. Yes, in alkalosis. Yes, you're right, Tarun. If I say acidosis shifts the curve to the right, alkalosis will shift the curve to the left. So, carbon monoxide poisoning, will you all agree with me if I say it's a form of anemia? Yes, right. What is the mechanism of carbon monoxide poisoning? Carbon monoxide has got very high affinity to Fe2 plus of hemoglobin. So, in the presence of carbon monoxide, more carbon monoxide binds to Fe2 plus, displacing oxygen. So, oxygen carrying capacity of hemoglobin is reduced and that is a form of anemia. So, carbon monoxide, though it's a form of anemia, it shifts the curve to the left because when carbon monoxide binds to Fe2 plus of hemoglobin, that hemoglobin is detached from the other three globin chains. Okay, and detachment will increase the affinity for oxygen. So, when carbon monoxide, suppose this is hemoglobin. Hemoglobin has got 4 heme and 4 globin chain. When one carbon monoxide binds to one heme, it increases the affinity for oxygen in the next heme. Do you understand this? It increases the affinity of oxygen in the next heme. So, affinity is increased and P50 is reduced. When P50 is reduced, the curve gets shifted to the left. Are you all clear about this? I want everybody here to know clearly about what happens to oxyhemoglobin dissociation curve in various conditions. Hypoxia, anemia, acidosis, increase in body temperature will shift the curve to the. Please explain about types of hemoglobin. We can't be explaining all types of hemoglobin during this session, Tarun. It's by itself a totally different topic. For now, listen to this, try to understand this. Hypoxia, anemia, increase in body temperature and acidosis will shift the curve to the right. There is one exception to anemia shifting the curve to the right. It is carbon monoxide poisoning. Carbon monoxide poisoning is a form of anemia because it displaces oxygen away. But when one carbon monoxide binds to one Fe2+, it increases the affinity for oxygen in the next Fe2+. Because affinity for oxygen is increased, P50 is reduced and the curve gets shifted to the left. Is that clear? So that's about this. So tell me the right answer for this, all of you now. Which of the following shifts the given curve to the left? Given curve to the left is shifted in decrease in body temperature. So this is a December 2020 question. Identify the vitamin deficiency. What is the image you see here? Do you see a castle's necklace? Yeah, do you see a castle's necklace appearance? Yeah. So castle's necklace appearance is one of the 3 Ds of pellagra. Pellagra is caused by what? Niacin deficiency. Pellagra is caused by niacin deficiency. Very good, all of you. So what is the right answer here? Right answer is choice C, niacin. So niacin deficiency pellagra, it presents as 3 Ds of pellagra. What are the 3 Ds of pellagra? The first one is diarrhea. The second one is dermatitis in the sun exposed area. So collar, yeah, in the neck around the collar, wherever it is exposed to sun, that is photosensitive dermatitis, which is hyperpigmented. That makes the person look as if the person has worn a necklace. So it is called as castle's necklace. And then dementia. Okay, diarrhea, dermatitis and dementia are caused by they are nothing but the 3 Ds of pellagra caused by niacin deficiency. Now this is again a December 2020 question. A 40-year-old man presented with pigmentation of sclera of eyes and pinna. The color of urine turns dark on standing. So color of urine turning dark on standing means what is it? Alkaptonuria. Yeah, what does alkapton means? Very good, Ghost Rider. What is alkapton? Alkapton means black. So what is alkaptonuria? It is black urine disease. And before we start discussing about alkaptonuria, can we discuss about all the other 3 choices? Because it's a rapid revision session, you should be able to understand about other choices also. So first about phenylketonuria. Tell me which enzyme defect causes phenylketonuria. Yeah, which enzyme deficiency causes phenylketonuria? It is phenylalanine. I am asking about phenylketonuria, Prithvi. It is caused by phenylalanine hydroxylase deficiency. So when phenylalanine hydroxylase is deficient, phenylalanine gets converted to phenylketones, that is by the name. And what is it characterized by? Very good, Prithvi, Muhammad, Alia, good. So what is it characterized by? It is characterized by number 1, mental retardation, number 2, mousy odor. Yeah, mental retardation, mousy odor and hypopigmentation. Okay, so mousy odor. How do you remember that phenylketonuria is characterized by mousy odor? Don't you know that mouse and keyboard go hand in hand always? Yeah, mouse and keyboard go hand in hand. Mousy odor, ketonuria. And then there is also hypopigmentation. Okay, and what are the 2 screening tests done to detect phenylketonuria? One is ferric chloride test, the other one is Guthrie's test. Yeah, one is ferric chloride test, the other one is Guthrie's test. First tell me about ferric chloride test, because this was asked once in FMGE. Ferric chloride test is done in urine, wherein to few ml of the patient's urine you add few drops of ferric chloride. As you add ferric chloride, there will be bluish or greenish discoloration. So if you see bluish or greenish discoloration of the urine on adding ferric chloride, it is positive for phenylketonuria. It's a screening test done to detect this condition. And then Guthrie's test is done in blood. Okay, Guthrie's test is done in blood. It is based on the fact that an organism Bacillus subtilis needs phenylketones for its growth. So what do we do in Guthrie's test? We take a colony, we take a colony plate of Bacillus subtilis organism, to which we add few drops of the patient's blood. And then we start counting the colony. If you see that the colony grows well, it means a blood sample has acted as a source of phenylketone. So that was considered as a screening test for phenylketonuria long time back. But it's a crude technique, because Bacillus subtilis could have grown for some reason, it could have died for some other reason. So both these tests are obsolete now. Ferric chloride test and Guthrie's test, both are obsolete now. But why am I telling you about all these tests? Because even recently there was a question on Guthrie's test. Guthrie's test is based on the presence of an organism. Which organism? Bacillus subtilis, which needs phenylketones for its growth. So if both these screening tests are outdated, what is the test that is done these days for phenylketonuria? Not only for phenylketonuria, for most of the inborn errors of amino acid metabolism, the first line screening test of choice would be HPLC with tandem mass spectrometry. Is that clear? What is the test? It is HPLC with tandem mass spectrometry. It is high performance liquid chromatography with tandem mass spectrometry that is done to detect most of the inborn errors of amino acid metabolism. So are you clear about phenylketonuria? So tell me which enzyme, very good Prince, which enzyme defect causes phenylketonuria? It is phenylalanine hydroxylase defect. What is it characterized by? Mental retardation, mousy odor, mouse and keyboard. Yeah, mousy odor, hypopigmentation. What are the two screening tests done to detect phenylketonuria? Ferric chloride test is done in urine, Guthrie's test is done in blood. But what is the better screening test? It is HPLC with tandem mass spectrometry. So we have excluded choice A. It is not phenylketonuria. Can it be maple syrup urine disease? Yeah, can it be maple syrup urine disease? No. What will it present as? Maple syrup urine disease is caused by the defect of branch chain keto acid dehydrogenase enzyme. Brown color hair, hypopigmentation, yes. Ramanathan Vairam, it is not medium chain fatty acid. Medium chain fatty acid oxidation defect does not cause maple syrup urine disease. Maple syrup urine disease is caused by branch chain amino acid metabolism disorder. The enzyme is branch chain keto acid dehydrogenase. And this enzyme is dependent on thiamine. Okay, and that is why maple syrup urine disease responds to thiamine administration. And what is it characterized by? Very good Prithvi, very good Alia. Yes, what is it characterized by? It is characterized by burnt sugar odor. Yeah, burnt sugar odor. How many of you have taken maple syrup? Most of you, right? Pancake with maple syrup. So how does it smell? It smells like burnt sugar. So it has burnt sugar odor of urine. And it also presents with what? It also presents with hypoglycemia and ketosis. Apart from burnt sugar odor, it also presents with hypoglycemia and ketosis. Very good, Prince. Yes, DNPH test. What is a screening test done to detect maple syrup urine disease? It is DNPH. What is DNPH? Dinitrophenylhydrazine test. Dinitrophenylhydrazine test is the screening test done to detect maple syrup urine disease. Yes, Rothera's test is done to detect ketone bodies in urine, and that gives purple colored ring. Okay, so maple syrup urine disease is DNPH test. So we have excluded that because history does not give anything about hypoglycemia. There is no mention about ketosis. There is no mention about burnt sugar odor. So this is not maple syrup urine disease. Now, can it be Hartnupp's disease? What is Hartnupp's disease? Anybody? Rafiq, Alia, Vairam, Prince. Very good. Rafiq, you're right. So what is the cause of Hartnupp's disease? Hartnupp's disease is malabsorption syndrome. It is tryptophan malabsorption syndrome. So I'm going to tell you about Hartnupp's disease. So Hartnupp's disease is caused by the defect of tryptophan absorption along the intestine. So there is one transporter which is responsible for tryptophan absorption along the intestine and for tryptophan reabsorption along the renal tubules. When that transporter is defective and tryptophan is not getting absorbed along the intestine, there will be tryptophan deficiency in the person. And I hope you all know that tryptophan is a precursor for niacin. Do you all know that? Yeah, tryptophan is a precursor for niacin. You must have learnt in your textbook that 60 milligram of tryptophan is equivalent to 1 milligram of niacin. So whenever there is tryptophan malabsorption, because there is tryptophan deficiency, there is niacin deficiency. And this niacin deficiency, just now I told you, will present as 3 Ds of pellagra. So the child will present with diarrhea, dermatitis and dementia. But because the same transporter is also responsible for tryptophan reabsorption along the renal tubule, when that is defective, that causes aminoaciduria. Do you all understand this? That causes aminoaciduria. So if you see a child with 3 Ds of pellagra, do not immediately say that there is dietary deficiency of niacin. This is not always dietary deficiency of niacin. This can even be tryptophan malabsorption. So how will you find out whether it's a dietary tryptophan malabsorption, whether it's a dietary tryptophan deficiency or is it tryptophan malabsorption? How will you differentiate the two conditions? If it is tryptophan malabsorption, then tryptophan will be found in urine also. So there will be aminoaciduria, and this will be an autosomal recessive disorder. Do you all understand this? This is an autosomal recessive disorder. So when there is excess tryptophan in urine, when this urine gets exposed to air, it gets oxidized. Tryptophan gets oxidized, and the indole ring of tryptophan gets oxidized to form ketol compounds. Yeah, indole ring of tryptophan gets, very good, blue diaper, excellent Prince. So indole ring of tryptophan, when it gets exposed to air, gets oxidized to form ketol compounds. These ketol compounds are blue in color. So this condition is called as blue diaper syndrome. So even here the color changes, the urine color changes, but the urine does not become black, the urine becomes blue. So blue diaper syndrome, what will be your suspicion? Your suspicion should be tryptophan malabsorption or Hartnupp's disease. Got it? So we have excluded Hartnupp's disease as well. So it is not phenylketonuria, it is not maple syrup urine disease, it is not Hartnupp's disease. So what are you left with? You are left with alkaptonuria. And every one of you should know in detail about alkaptonuria, because alkaptonuria is common in India. So it's not always about answering an MCQ. Only because it's common in India, it is being questioned always. So let's learn all about alkaptonuria. So what is alkaptonuria due to? Alkaptonuria is because of the defect of homogentisate oxidase. Even if you know nothing about homogentisate oxidase, don't you think that it should act on homogentisic acid? It acts on homogentisic acid. So whenever homogentisate oxidase is deficient, homogentisic acid accumulates in the circulation. It gets accumulated in the tissues. Whenever it gets accumulated, it gets oxidized to form benzoquinone acetate. Homogentisic acid on accumulation will get oxidized to form benzoquinone acetate, and this benzoquinone acetate undergoes polymerization to form melanin-like fibrils. And when these melanin-like fibrils accumulate in cartilages, this causes cartilage destruction. And this cartilage destruction is the reason for ochronosis. So what will alkaptonuric patient's urine present with? Yes, black discoloration of urine on exposure to air. So but what will the patient present with? The patient will be absolutely normal till mid-age. Close to mid-age, they come with complaints of multiple joints involvement, multiple intervertebral disc bulges and prolapses, knee pain. Okay, that is why it's called as ochronosis. And this accumulation of melanin-like fibril also happens in skin. Okay, it happens in skin and mucous membrane. Because it accumulates in skin, you will see black pigmentation of pinna. What will you see? You will see black pigmentation of pinna, tip of the nose, thenar and hypothenar eminences will also be pigmented. And when it accumulates in mucous membrane, it causes Osler's sign. So all of you tell me, what is the first sign of alkaptonuria? Symptom is something which the person complains about. Sign is something which you identify. So what will you be able to identify the first in a patient of alkaptonuria? Osler's sign. What is Osler's sign? Accumulation of black color. Yeah, black color pigmentation of sclera along the attachment of both medial rectus and lateral rectus. That is Osler's sign, the first sign of alkaptonuria. And melanin-like fibril is also formed in the urine after the urine is passed out. So the urine turns dark on standing. That is why the name alkaptonuria. Is that clear? So tell me all that you have learned about. I will tell you about the treatment now, Tarun. First tell me what is, that's a good question, Tarun. I will tell you about it. No, it is not pyridoxine. It is vitamin C. Yeah, vitamin C is the treatment for alkaptonuria. So first tell me all the facts that I've told you about alkaptonuria. Alkaptonuria is an inborn error of metabolism caused by the defect of homogentisate oxidase. When homogentisate oxidase is defective, the precursor homogentisic acid accumulates, which gets converted to benzoquinone acetate. that on polymerization forms melanin-like fibrils. These melanin-like fibrils accumulate in cartilages causing ochronosis. They accumulate in sign causing black pigmentation of pinna, tip of the nose, thenar and hypothenar eminences. Accumulation mucous membrane causes oscillor sign, and urine turns dark on standing. Okay, and this homogenesic acid is a reducing substance. So alkapnuric patients' urine will answer Benedict's test. Benedict's test will be positive in alkaptonuria. Okay, and there was a question about treatment of alkaptonuria. So the entire defect, the entire defect happens because of two reasons. One is accumulation of homogenesic acid, the other one is oxidation of homogenesic acid. So can you prevent oxidation by giving an antioxidant? All of you tell me yes or no. Can you prevent oxidation by giving an antioxidant? Yes. And what is the famous antioxidant vitamin? It is vitamin C. And that is why vitamin C is given in mega doses in alkapnuria to prevent oxidation of homogenesic acid to form benzoquinone acetate. Another way of treating alkapnuria is by reducing the generation of homogenesic acid. How can you reduce the generation of homogenesic acid? In tyrosine metabolism, all of you listen to this. In tyrosine metabolism, there is a precursor para-hydroxyphenyl pyruvate. Only when para-hydroxyphenyl pyruvate dioxygenase acts on it, it gets converted to homogenesic acid. So if you want to suppress the generation of homogenesic acid, which enzyme should you inhibit? I'm going to tell you, Prince Davis, you're right. Yeah, so which enzyme should you inhibit? You should inhibit para-hydroxyphenyl pyruvate dioxygenase. So which drug inhibits para-hydroxyphenyl pyruvate dioxygenase? It is nitisinone. Yeah, what is it? It is nitisinone. Excellent, Prince Davis. You are answering everything excellently. So nitisinone acts by inhibiting para-hydroxyphenyl pyruvate dioxygenase that is used to treat alkaptonuria. And the same nitisinone is also used for treating type 1 tyrosinemia. Yeah, so what are the two indications for nitisinone? Type 1 tyrosinemia and alkaptonuria. Clear? So what is the right answer here? Because urine turns dark on standing, you know very well it is alkaptonuria. If they say urine turns blue, what will be your answer? Hartnupp's disease. And along with that, what will you also see? You will also see 3 Ds of pellagra. Good, Nigar Ansari. Answer is choice D. Okay. Complex 4 is inhibited by what? Yeah. Complex 4 is inhibited by cyanide. The famous one, yeah, cyanide inhibits complex 4. Okay, so let's learn about all electron transport chain inhibitors. Again, it's a December 2020 question, so there is a high probability that you're asked about some other inhibitor of electron transport chain. So let's learn about all electron transport chain inhibitors. But before that, you should know about complexes of electron transport chain. So I'm going to tell you everything in a nutshell, a quick summary of electron transport chain complexes and about their inhibitors. Okay, so how many complexes do you have in electron transport chain? They have 5 stationary complexes and 2 mobile complexes. Please memorize it. They have 5 stationary complexes and 2 mobile complexes. What are the 5 stationary complexes? It is complex 1, complex 2. All of these are numbered in Roman letters. Stationary complexes are all numbered in Roman letter. Complex 1, 2, 3 and complex 4. The last one, complex 5, is ATP synthase complex. Which is complex 5? It is ATP synthase complex. All these are stationary complexes. Okay. Now, what is complex 1? Complex 1 is NADH linked dehydrogenase. That is electrons from NADH. There is a probability, Tarun. I cannot assure you of this, right? Yeah, one. There is, do you understand that in any question paper, yeah, however tough the question paper is, in all question papers, at least 80% there will be a repeat. When I say repeat, it will not be an exact repeat. They will not exactly ask you complex 4 is inhibited by what. they will ask something similar to that. So if you learn in detail about the topic in which previously questions have been asked, there is a very high probability that you will be able to answer many questions in the upcoming exam. That is why it is mandatory that you work out all previous year question papers. Yeah, please do that without fail. At least last 4-year FMGE question papers. When I say 4-year question papers, totally you'll have 8 question papers. So please work out last year, all the latest 8 question papers in FMGE before you appear for your exam. Okay, and when I say work out, read all relevant facts and concepts. Okay, so complex 1 is NADH linked dehydrogenase. Complex 2 is succinate dehydrogenase. Yeah, complex 2 is succinate dehydrogenase. Complex 3 is cytochrome B and C1. You don't have to be sorry, okay? All that I want you to is to be interactive during the session and keep learning multiple facts and concepts. Why will you want mnemonic to remember complex names? Yeah, complex names are very simple, right? Complex 1 is the complex through which NADH enters into electron transport chain. Complex 2 is succinate dehydrogenase. Complex 3 is cytochrome B and cytochrome C1. Complex 4 is cytochrome A and cytochrome A3. Yeah, complex 4 is cytochrome A and cytochrome A3. Complex 5 is ATP synthase complex. Clear? So these are the 5 stationary complexes. Now what are the mobile complexes? Mobile complexes include Q. Substances, yes, there are mnemonics. I will tell you about that now. Okay, so let's first learn about the complexes. Let's learn the direction. Only when you know the direction, you will understand which inhibitor acts where. Okay, so what are the 2 mobile complexes? The 2 mobile complexes are ubiquinone or Q placed between 1 and 3 and cytochrome C placed between 3 and 4. So all of you tell me what are the 2 mobile complexes? Ubiquinone or Q placed between 1 and 3 and cytochrome C placed between 3 and 4. Okay, so why do you want such mobile complexes between stationary complexes? These mobile complexes go to one complex. For example, Q goes to complex 1, collects electron from complex 1, drops it in 3. C goes to 3, collects electron from 3, drops it in 4. So to facilitate electron transport between stationary complexes, you have mobile complexes. Now what is the direction of transport of electrons? Yeah, the direction of transport of electron is if it's NADH. From NADH, electrons enter into complex 1. Let me show you the direction in pink color. So from NADH, electrons enter into complex 1. From complex 1, electrons go to Q. From Q to 3, 3 to C, C to 4, and from 4, from 4, which is the final acceptor of electron. The final acceptor of electron is oxygen. Yeah, which is the final acceptor of electron? It is oxygen. This is for NADH electron. If it is FADH2 electron, mostly it enters into electron transport chain through complex 2. From complex 2, electrons go to Q. From here we know, right? From Q it goes to 3, 3 to C, C to 4 and 4 to oxygen. So this is the direction of transport of electron. Now let's learn about electron transport chain inhibitors. I am going to show you all electron transport chain inhibitors in red color. So electron transport between complex 1 and Q. Yeah, electron transport between complex 1 and Q is inhibited by amobarbital. Please repeat it along with me. What is it? It is amobarbital, pyrisidin A and rotenone. Okay, amobarbital, pyrisidin A and rotenone. So who was asking me? I think Prince Davis was asking me how do we remember it. Yeah, to remember this, which is the first alphabet, all of you? The first alphabet is A. So between 1 and Q, all 3 names have got something to do with A. For example, the first name amobarbital, name starts with A. Amobarbital, name starts with A. Pyrisidin A, name ends with A. And then rotenone, it sounds like vitamin A, right? It is not vitamin A, but don't you think it sounds like vitamin A? So amobarbital, pyrisidin A and rotenone, all these inhibit electron transport between complex 1 and complex Q. Now complex 2 is inhibited by, complex 2 is succinate dehydrogenase, that is inhibited by malonate. Yeah, succinate dehydrogenase is inhibited by malonate. And then electron transport between 2 and Q here, yeah, between 2 and Q is inhibited by TTFA. 2 starts with which alphabet? 2 starts with T. And 2 to Q is inhibited by TTFA and carboxyl. Please memorize it. Between 2 and Q is inhibited by TTFA and carboxyl. Electron transport between 3 and C. Yeah, electron transport between 3 and C is inhibited by BAL and antimycin. Yeah, BAL, 3. Do you see 3 letters in BAL? So between 3 and C is inhibited by BAL. No, malate and malonate are totally different, Kirti. Malate is something which we have in our body. Yeah, malate is an intermediate of citric acid cycle and it's a part of malate shuttle. That's a good compound. Malonate is a toxin. Yeah, malonate is a toxin which acts by inhibiting succinate dehydrogenase. They're totally different, Kirti. Okay, so between 3 and C is inhibited by BAL and antimycin. Please don't get confused here. Antimycin's name starts with A. It has got nothing to do with 1 and Q. Okay. Now the last one, between complex 4 and oxygen, electron transport between 4 and oxygen is inhibited by hydrogen sulfide, cyanide and carbon monoxide. Yeah, electron transport between 4 and oxygen is inhibited by hydrogen sulfide, cyanide and carbon monoxide. So can you quickly repeat this? Have a look at the image, yeah, that is shown here, and please tell me about all the inhibitors. Which inhibitor inhibits between 1 and Q? Between 1 and Q, first alphabet is A, so it is amobarbitol, pyrisidin A and rotenone. Complex 2 or succinate dehydrogenase is inhibited by malonate. Electron transport between 2 and Q is inhibited by 2 starts with T, so it is TTFA and carboxyl. Between 3 and C is inhibited by, yeah, between 3 and C is inhibited by BAL and antimycin. Between 4 and oxygen is inhibited by hydrogen sulfide, cyanide and carbon monoxide. So do you understand that cyanide inhibits complex 4? Okay. And though I say that carbon monoxide inhibits electron transport between 4 and oxygen, are you worried about carbon monoxide for this reason? I am very happy that the chat box is active. Very good. So do you think you are worried about carbon monoxide poisoning just because it inhibits electron transport between 4 and oxygen? No. Why are you worried about it? You are worried about it because, as I told you in the previous question, carbon monoxide exhibits very high affinity to Fe2 plus of hemoglobin, so it displaces oxygen away. So it causes anemia. You are worried about carbon monoxide poisoning because it causes anemia, but additionally it also inhibits electron transport between complex 4 and oxygen. Okay. So what is the answer here? Complex 4 is inhibited by cyanide. Okay. And apart from the inhibitors which I told you just now, I want you to know about uncouplers. Yeah, I want you to know about uncouplers. What do uncouplers do? Yeah, so first tell me, what does electron transport chain couple? If this is electron transport chain, it couples oxidation with phosphorylation. What does it mean? Fuels are getting oxidized. Yeah, fuels are getting oxidized and energy is getting liberated. It is this electron transport chain which couples the energy that is getting liberated to phosphorylation of ADP to form ATP. Do you all understand this? Yeah, what does electron transport chain do? Electron transport chain couples oxidation with phosphorylation. That is, whenever fuels get oxidized, energy is liberated and that energy is converted to ATP, and that coupling is done by ETC. Now, what does an uncoupler do? Uncoupler uncouples. Yeah, uncoupler uncouples oxidation from phosphorylation, in the sense oxidation of fuel will happen continuously without phosphorylation. So when there is no phosphorylation, what will not be generated? All of you tell me. When there is no phosphorylation, what will happen? ATP will not be generated. But even here, there is oxidation of fuel happening continuously, and even here energy is getting liberated. You are not using that energy for forming ATP. When you don't use the energy, energy will be liberated out as heat. Yeah, energy will be liberated out as heat. And as one of you had mentioned, who mentioned it? Viram. Yes. So it causes heat generation. No ATP production, only heat production. When there is no ATP production, for want of ATP, more and more fuels will get oxidized. The body does not know why there is no ATP. So what will it do? It will increase the rate of oxidation of all the fuels. Yeah, it increases the rate of oxidation of all the fuels. So these are the effects of uncouplers. Are you clear about this? So what are uncouplers? What do they do? Uncouplers uncouple oxidation from phosphorylation. That is, oxidation of fuel happens continuously without phosphorylation. When there is no phosphorylation, no ATP production. But oxidation is liberating energy. That energy will be liberated out as heat. So no ATP production, increased heat production. When there is no ATP production, for want of ATP, more and more fuels will be oxidized. So there will be increase in the rate of oxidation of all the fuels. Okay. Now what are the examples of uncouplers? Can anybody tell me? What are the examples of uncouplers? Uncoupler is also a favorite topic in FMGE. There are two types of uncouplers. One is physiological uncoupler. Very good, Byram. One is physiological uncoupler. The other one is artificial uncouplers. So what are the physiological uncouplers? The first one is thyroxine. Don't we always say that thyroxine increases heat production? Right? And we say thyroxine increases basal metabolic rate. How do you think thyroxine does that? It upregulates uncoupler proteins in the inner mitochondrial membrane. It facilitates uncoupling mechanism. That is why it increases heat production. Another example for physiological uncoupler is brown adipose tissue. Yeah, another example for physiological uncoupler is brown adipose tissue. Tell me, why is brown adipose tissue brown? Can anybody tell me why is brown adipose tissue brown? Because it has got numerous mitochondria. And in all these mitochondrial inner membranes, what is your fact about long chain fatty acid? Yes. So why are they brown? Not because of hemoglobin, Byram, because they have numerous mitochondria. And in all these mitochondrial inner membranes of brown adipose tissue, uncoupler proteins are inserted. And because of these uncouplers, no ATP production, only heat production. And that is why brown adipose tissue acts as a mechanism for non-shivering thermogenesis in neonates. Do you all understand this? Neonates do not exhibit shivering. So how do they increase heat production? At the time of birth, we are born with a particular amount of brown adipose tissue that keeps generating heat. In between scapula is where we have excess brown adipose tissue when we are born. So brown adipose tissue acts as a mechanism for non-shivering thermogenesis, and these two are the examples for physiological uncouplers. Now what are the examples for artificial uncouplers? Artificial uncouplers include 2,4-dinitrophenol. Yeah, artificial uncouplers include 2,4-dinitrophenol, valinomycin, nalinomycin and nigericin. So what are the examples of artificial uncouplers? 2,4-dinitrophenol, valinomycin, nalinomycin and nigericin. So all these are uncouplers. Now how does oligomycin act? Though the name sounds similar, valinomycin, nalinomycin, nigericin is one group, oligomycin is a totally different group. So how does oligomycin act? It acts by inhibiting ATP synthase complex. Okay, it acts by inhibiting complex 5 or ATP synthase complex. Now look at this question and tell me the right answer. Complex 4 is inhibited by what will be your answer? Your answer will be cyanide. Tell me about rotenone. Where does rotenone act? I told you rotenone sounds like vitamin A. So vitamin A, rotenone, it inhibits electron transport between 1 and Q. How does malonate act? Very good, Rafiq. Good, Alia. Good, Byram. Kavita. Hi, Kavita. Yes. So malonate acts by inhibiting succinate dehydrogenase. Excellent. How does oligomycin act? Oligomycin inhibits ATP synthase complex. So the answer is cyanide. True about mitochondrial DNA is? Tell me which is the right answer. Mitochondrial DNA, is it open? Is it linear? Is it double-stranded DNA or single-stranded DNA? Very good, Ghost Rider. Very good, Byram. Others, please. 2 of them have chosen choice C as the right answer. Others, Ansari, Rafiq, Prithvi, good. Storage revision, very good. Good name. Please ask me, Kavita. If it's an academic doubt, please ask me. So what is the right answer? True about mitochondrial DNA is double-stranded DNA. Okay. So what are the facts that you know about mitochondrial DNA? Mitochondrial DNA is a closed circular double-stranded DNA. Is that clear? The first fact about mitochondrial DNA is it is closed circular double-stranded DNA similar to plasmids of prokaryotes. So we actually consider mitochondria as a prokaryote which has gained entry into eukaryote. But because we identified that it provides us with some survival advantage, we have allowed this mitochondria to get into symbiosis. So mitochondrial DNA is closed circular double-stranded DNA similar to plasmids of prokaryotes. And though mitochondria has got its own DNA, not all proteins of mitochondria are coded by the same. Mitochondrial DNA codes only for 13 proteins of electron transport chain. The remaining proteins are coded only by nuclear DNA. And mitochondrial DNA codes only for 22 tRNAs and 2 ribosomal RNAs. So tell me, what are the facts which are coded by mitochondrial DNA? Mitochondrial DNA codes for 13 proteins of electron transport chain, 22 tRNAs and 2 ribosomal RNAs. I have no idea about that. I don't know who's Tanshuk sir. I'm sorry. I don't think I'll be able to help you on that, Kavita. I don't know. Yeah, so tell me, what are the substances which are coded by a mitochondrial DNA? It codes for 13 proteins of electron transport chain, 22 tRNAs and 2 ribosomal RNAs. Okay. And the next fact about mitochondrial DNA is the genetic code here is quite different. Do you understand this? Mitochondrial DNA, the genetic code is quite different. For example, what is UGA? Symbiosis is 2 organisms living together. Tarun. 2 organisms living together. So mitochondria probably is a prokaryote which has gained entry into eukaryote. Now we are living together. Yes, very good, Rafiq. Excellent. Yes. So UGA is usually a stop codon in nuclear DNA. But the same UGA codes for tryptophan in mitochondria. In mitochondrial DNA, UGA codes for tryptophan. Okay. And usually AGA and AGG code for arginine. Yeah, usually AG and AGG code for arginine. In mitochondrial DNA, both act as stop codons. So can you tell me what is the difference in genetic code of mitochondrial DNA? The first difference is UGA is not a stop codon, but it codes for tryptophan. AGA and AGG, they act as stop codons here. And mitochondrial DNA is more prone to get mutated. Yeah, what is the difference here? Mitochondrial DNA is more prone to get mutated because DNA polymerase gamma, which synthesizes mitochondrial DNA, does not have proofreading and repair activity. Do you understand this? So this can be asked as a simple question. Which DNA polymerase synthesizes mitochondrial DNA? It is DNA polymerase gamma. And that DNA polymerase gamma does not have proofreading and repair activity. That is why mitochondrial DNA is more prone to get mutated. And such mitochondrial DNA mutations are only maternally inherited. Yeah, why are they only maternally inherited? Because during zygote formation, all that the sperm contributes with is its pronucleus. And the remaining part of the sperm will be shed down. So even if the remaining part of the sperm has mitochondria, they have numerous mitochondria, even if that mitochondrial DNA is mutated because it does not gain entry into zygote, it is not going to be inherited by the fetus. Do you understand this? So mitochondrial DNA mutations are always maternally inherited. So these are the facts that you need to know about mitochondrial DNA. It is a closed circular double-stranded DNA coding only for 13 proteins of electron transport chain and for 22 tRNAs and 2 ribosomal RNAs. So what is the right answer here? The right answer here is true about mitochondrial DNAs. It is a double-stranded DNA. Clear? So this is the last question for this session. DNA polymerase requires all except. I want all of you to listen to this because this will tell you about requirements of PCR. Okay, so DNA polymerase requires all except. Does it need a primer? Does it need 3' 5' strand to act as a template? Is it stuck? Keith is saying it is stuck. Can you all see me? Please tell me. DNA polymerase requires all except. I will discuss that in another session, Tarun, because the time is up. I have only 2 more minutes. Very good. Ghost Rider is right. 5', 3' strand is never used as a template. All of you, 5', 3' strand is never used as a template because memorize it, all your polymerases, be it DNA polymerase or RNA polymerase, all your polymerases can synthesize a new strand only in 5', 3' direction. Is that clear? All your polymerases can synthesize a new strand only in 5', 3' direction. If they can synthesize a new strand only in 5', 3' direction, what should be the direction of the template strand? Template strand has to be anti-parallel. So template strand is always 3', 5'. Clear? Template strand is always 3', 5'. So now I am going to tell you about requirements of DNA polymerases. So what are the requirements? All DNA polymerases need a template strand to be already present. Only then they will be able to synthesize a new strand which is complementary and anti-parallel. And what did I tell you is the direction in which DNA polymerases synthesize a new strand. They always synthesize a new strand only in 5', 3' direction. So if they can synthesize a new strand only in 5', 3' direction, what should be the direction of the template strand? The template strand is always in 3', 5' direction. Is that clear to all of you? Template strand, if you see the word template strand, you can close your eyes and say it is 3', 5'. And if they ask you, an enzyme synthesizes a new strand in which direction? Is always 5', 3'. So what is the first requirement of all DNA polymerases? All DNA polymerases need a 3', 5' strand to act as a template. Only then they can synthesize a new strand in 5', 3' direction. Second requirement is all these DNA polymerases need a primer. Yeah, they cannot synthesize a new DNA strand out of thin air. Only until there is a primer, they can elongate a new strand. So the second requirement is primer. Third requirement is they always need all 4 deoxynucleotide triphosphates. What do I mean by all 4 deoxynucleotide triphosphates? Deoxy-ATP, deoxy-GTP, deoxy-CTP and deoxy-TTP. You should provide all 4 deoxynucleotide triphosphates. Why should you provide all these 4? What do these enzymes do? These enzymes just read the template strand. And suppose the template strand shows T. What will this enzyme do? The enzyme will recruit A. Yeah, they will recruit A. But what is a form of nucleotide that is present in a polynucleotide chain? Be it DNA or RNA, all polynucleotide chains have only monophosphate nucleotides. Do you understand this? All your polynucleotide chains have only monophosphate nucleotides. But why are they recruiting complementary nucleotide triphosphates? Because they recruit complementary nucleotides and they link these complementary nucleotides by forming a phosphodiester linkage. So tell me, what is the linkage that is present in a polynucleotide chain? The linkage that is present in any polynucleotide chain is 3', 5' phosphodiester linkages. So for forming these phosphodiester linkages, they need energy. From where will they recruit energy? They recruit complementary nucleotide triphosphates. They break last 2 linkages. They get energy out of them. They use that energy for forming 3', 5' phosphodiester linkages. Is that clear? Yeah. So what is the third requirement for all DNA polymerases? All your DNA polymerases need all 4 deoxynucleotide triphosphates. They always need magnesium or manganese to act as a catalyst. All your DNA polymerases need magnesium or manganese to act as a catalyst. They always need a buffer. Yeah, they always need a buffer to maintain the pH. So phosphodiesterase. Tarun, phosphodiesterase is an enzyme. That enzyme is inhibited by sildenafil. What we are discussing now is phosphodiester linkage. Both are totally different. Do you understand that, Tarun? Yeah. So tell me, what are the requirements of all DNA polymerases? All DNA polymerases, first they need a template strand. What should be the direction of the template strand? The template strand should always be in 3', 5' direction. Only then they can synthesize a new strand in 5', 3' direction. Okay. Second requirement, they always need a primer. Only then they can elongate a new strand. Third requirement, they need all 4 deoxynucleotide triphosphates. Okay, what do they do with all these 4 deoxynucleotide triphosphates? They break last 2 linkages. They use that linkage to form 3', 5' phosphodiester linkages here. So deoxynucleotide triphosphates. They always need magnesium or manganese to act as a catalyst. They always need a buffer. Got it? Yeah, so tell me, what is the right answer for this question? For this question, do they need a primer? Tell me yes or no. Yes, all DNA polymerases need a primer. Do they need a 3', 5' strand to act as a template? Yes, they need it. Do they need all 4 deoxynucleotide triphosphates? Yes. Do they need 5', 3' strand to act as a template? No. Template is always in 3', 5' direction. Okay. So that is all for today. I will continue this marathon probably in another 2 days. Yeah, in another 2 days we'll schedule one more session wherein I will tell you all about molecular biology techniques. Tarun was asking about PCR. I will discuss about PCR when we discuss the next session. Okay. Thank you. All the best.